Next, we have Dr. Shine NS, who will be talking on OCTA as a diagnostic tool in intermediate and posterior uveitis, a clinical and imaging study.
Good morning all. My topic for paper presentation is assessment of optical coherence tomography angiography features in uveitis. OCTA, otherwise called as OCTA, it utilizes advances in OCT technology. It gives us high resolution angiographic information in a non-invasive, non-dye method correlated with the OCT B scans. Aim of our study is to assess the OCTA features in uveitis, enhancing the diagnostic accuracy and understanding various intermediate and posterior uveitis conditions. It was a prospective observational descriptive study which was done in patients diagnosed with intermediate and posterior uveitis. It was done for 18 months and in 84 eyes. We included patients diagnosed with intermediate and posterior uveitis and patients aged 10 years and above. We excluded patients with weak OCTA signals due to corneal and lens opacities and with other retinal pathologies. All the patients undergone complete ophthalmological examination and diagnosis of posterior or intermediate uveitis made, and laboratory radiological investigations were conducted as needed. All patients undergone OCTA imaging acquired using Heidelberg Spectralis OCTA system on presentation and follow-up. This is an interface showing Heidelberg Spectralis OCTA. We can divide the layers by layer: superficial vascular complex, deep vascular complex, and avascular complex, and choriocapillaries and choroid. Automatic segmentation. Also, we can do manual segmentation. Coming to result, the main disease type we encountered in our study was BKH, and followed by toxoretinochoroiditis and serpiginous choroiditis. The findings in superficial capillary plexus was less, and we could find out a significant amount of artifacts in this layer. In deep capillary plexus layer, flow deficit area was the main feature. In outer retina, we could find out neovascularization and CMVM almost 4% of patients. This is image of CNVM in OCTA interface. In choriocapillary layer, the flow void areas was the main finding. This is an image of flow void areas in a choriocapillary layering in OCTA imaging. In choroid also, flow void areas was the main findings. We could find out almost 12% of artifacts in these eyes. It was increasing from deeper to superficial layers. And also we could note the change of area in, by subsequent OCTA, and the main finding of flow void areas was decreased in subsequent follow-up. It was decreased in 42% of patients, and it was correlating with the best corrected visual acuity in patients, which was improved with the improvement in the area. And we could find out neovascularization and CNVM in follow-up visit in patients before the symptoms appear. And further similar studies were done which revealed correlation between microvascular changes and clinical parameters, which aiding in the early diagnosis and management of uveitis. Similar studies by Melachuri et al., Dinkarkas et al., and Tranospi et al. Showed lesions in superficial capillary and deep capillary plexus detected by OCTA. Deep capillary plexus findings was more than superficial capillary plexus, and also superficial capillary plexus had higher number of artifacts in these studies also. In Herbert et al. And Tranospi et al., the avascular complex layer also got almost 17% of changes, and also similar to their study, we were able to detect neovascularization CNVM in these layers. In multiple studies showed choriocapillary and choroid layer have flow void areas as the main findings, which was similar to our study. A limitation to our study is we only use qualitative assessment with the OCTA, and not every patient had follow-up with the OCTA imaging, and acute conditions had more segmentation errors and poor image quality, and there was a lack of comparison with other imaging modalities like FFA, ICGA, and OCTA does not detect vascular leakage, which was important for inflammatory vasculopathy. To conclude, OCTA effectively identified various pathological changes in retinal and choroidal vasculature, including the various layers, and the significant association between these changes and uveitis highlight the potential of OCTA as a diagnostic and monitoring tool. we recommend OCTA as an adjunctive tool with along with the fundus imaging, FFA, ICGA to objectively evaluate inflammatory status of the uveitic eyes. So, and presence of artifacts in OCTA images necessitate the careful interpretation to avoid misdiagnosis. Also, we should have training and experience in OCTA interpretation for a crucial, accurate assessment. These are my references. Thank you.
It was a good study first time we are seeing in Uveitis, I think. Is it practically possible?
Yes, madam. Because it's a non-invasive, we are not using a dye. Multiple FFA or ICGA episode we could avoid, and also if we are the financial constraint, if it's not there, we can use it for multiple imaging for follow-up mainly.
Okay. But follow-up means again every time you have to keep on doing, right?
And,
So
no,
will not that be a burden for the patient?
if we find out any changes in fundus examination or any symptoms, early symptoms, we could pick up early CNVM or neovascularization is layer by layer without dye injections in the patients. So it will be useful for patient having any contraindication for dye injections, madam.
Okay, right.
There is no improvement in spite of treatment and
Yes, ma'am.
was there any past practice in your study?
There was 10% of patients was there, but there was
Past practice. Without any etiology? No, not more.
etiologies was there,
Intermediate.
intermediate use was there, but OCTA findings were very less, because if there was a neovascularization into the vitreous, we could find out
They are the double component, posterior and intermediate.
intermediate.
So relatively posterior uveitis has
More findings and intermediate. If they had a neovascularization coming into the vitreous, we could find out. Otherwise, less findings was there.
So even pars planitis, they will manifest as macular edema. The most common cause for visual loss in pars planitis, macular edema.
Yes.
They will come to you.
If there is edema, the acute conditions, if there is higher edema and distortion of inner layers, there will be segmentation errors and the artifacts more in the superficial layers. So it,
get it with your OCT only.
oh yes, sir.
May not do.
Oh yes.
Thank you.